Good evening. Welcome to our fourth webinar for the Lebanese Fertility Society. It's one of multiple webinars that could cover until now a big part of our specialty. Big thanks for Merck to make it happen today. This evening, we are going to talk about implantation and uterus in IVF. We'll talk about updates and new trends in implantation with the know-how of our best expert in the Lebanese Fertility Society. What evidence we have to improve implantation rate? In the future, all investigations, preparations will follow only evidence-based medicine rules. Lines of treatment not confirmed by sound evidence will be obsolete. First thing, 3D ultrasound will remain a routine test. We will see the size of the uterus, polyps, fibroids, hydrosalpinx, antral follicle count, endometriomas, pelvic or ovarian lesions. So it should be a routine test and systematic before any IVF treatment. In IVF, hysteroscopy will be done only if there is a suspected abnormality seen in 3D ultrasound. Systematic hysteroscopy before first IVF, there's a multicenter randomized trial done by Smith. In this trial, there was 363 with hysteroscopy and 377 without hysteroscopy. There is no difference between the two groups. So there is no indication for a systematic hysteroscopy before IVF. Recurrent in vitro fertilization failure, trophy study, it's a randomized controlled study also. It includes patients with 2 to 4 unsuccessful IVF cycles. There is no difference between hysteroscopy and no hysteroscopy before IVF. For the luteal phase support, progesterone alone is effective. This is confirmed. There is no difference if we start progesterone at day of HCG, day of oocyte collection, or day of embryo transfer. And we can stop progesterone the day of beta HCG or the day of the first ultrasound. What about the combined adjuvant therapy like aspirin, doxycycline, and prednisolone in IVF? A study done over 485 patients shows no difference if we treat patients with aspirin, doxycycline, or prednisolone during IVF cycles. So there is no evidence to use these treatments as adjuvant to improve implantation rate. What about heparin? A Cochrane review done in 2015, over 386 women randomized. There is no difference for patients with a treatment of heparin to improve the live birth rate after IVF. For aspirin or heparin, for patients with unexplained recurrent miscarriage, there is no benefit of anticoagulant, even if there is inherited thrombophilia. A Cochrane review also done in 2014. For uterine natural killer, the problem is the function of this uterine natural killer is unknown until now. There is a lack of scientific rationale. We should be very careful in evaluating the practice of immunomodulation to enhance pregnancy outcome. So there is no indication until now with evidence-based medicine to use immunomodulation to improve implantation rates. What about the day of transfer? If we use the day 3 or day 5 to improve cumulative live birth rates? A big study done in 2016 shows there's a live birth rates per started cycle significantly lower if we transfer on day 3. But the cumulative live birth rate was the same between day 3 and day 5. So if we use cumulative live birth rate, we'll have the same data if we transfer on day 3 or day 5 for live birth rate issue. What about PGS? PGS is a screening test. So it should be done for all patients, all embryo, for all chromosomes. This does not happen anywhere in the world. It's used only for selected groups of patients. In big meta-analysis, including 9 studies, in advanced maternal age, PGS reduced live birth rate. And in good prognosis, there is no improvement of live birth rate. So there's no evidence that PGS improve live birth rate after IVF. Other studies show that include advanced maternal age, recurrent miscarriage, and repeated implantation failure did not show any improvement with PGS treatment before transfer in IVF treatment. Problem of PGS that the hypothesis of PGS was based on 5 assumptions. IVF fails because of aneuploid embryos. Elimination of aneuploid embryos improves outcome. Will a single trophectoderm cell represent the whole trophectoderm? Trophectoderm examined cells represent cells of the inner cell mass, and the ploidy does not change, no self-correction. All the 5 points were found to be mistaken. That's why the results of PGS on live birth rate was not the results that we will be happy to have. And that's why PGS does not have any evidence-based medicine to improve live birth rate. What are the evidence to improve implantation? When the surgical treatment of the uterus improved the implantation, all this topic was being discussed in our webinar. Our chairman, Dr. Rana, she's an IVF specialist in Makassed Hospital, will introduce our speakers and will moderate our webinar. Thank you, Dr. Tell. The floor is yours. I think Dr. Tell is disconnected. So I will introduce Dr. Hanoun. Dr. Hanoun is an IVF specialist. He's a professor in gynecology and an IVF specialist in American University of Beirut. He will talk this night about implantation. So please, Dr. Hanoun, you can start your topic.
Okay, good evening, everybody who's listening to us. I will talk about implantation and specifically concentrating on the uterus. We know that we have many major breakthroughs in our treatment for infertility, the introduction of IVF per se, the introduction of ICSI. But since the introduction of ICSI in the early 1990s, we don't think that we have really a major breakthrough in our treatment for IVF. Why? Because we have still what I call the rate limiting step in achieving a pregnancy, which is the last step, implantation. And if we do anything and we do not have implantation, no pregnancy, so we are failing our treatment of infertility. So we know that we have invasive properties of the trophoblast. Would implantation is just a mechanical phenomenon? I mean, would the growing embryo invade the endometrium at a place that it chooses, or it is not? In fact, it's non-mechanical. And quickly, we have three phases in implantation: apposition, adhesion, and invasion. And the apposition, we know that the embryo will choose a place to implant it, but it has to grow microvilli, pinopods, etc. But we know that the attachment here is not strong. This embryo can be washed away from its place of attachment. Whereas in adhesion, we have attachment, a strong attachment of the embryo in the endometrial lining, but because of the thinning of the endometrial lining, the endometrium is helping that embryo to attach. The third step is invasion. I mentioned this quickly to tell you that it's not mechanical. There are many factors secreted by the growing embryo, and many also factors secreted by the receptive endometrium in order for a successful implantation to occur. It's not the place to talk about all these factors and growth factors and immune factors, etc. But we have many factors. We discovered a lot of them, but we're still a big portion or a big part we don't know about. Now, I will concentrate on what we call repeated implantation failure. I will call it RIF to be fast. For RIF, we still have controversies. We still have controversies in the definition of RIF. Is it after 2 failed good quality embryo transfer? Is it after 3, after 4? So we do not have a unique definition if you review the publications. And is a 3 failed embryo transfer in a 40-year-old the same as a 3 failed embryo transfers in a 20-year-old? Definitely it's different. What diagnostic workup we have? We have many interventions. We have many causes for repeated for RIF. What's the treatment? So the place here is not to talk about all these. We have, this slide will show that we have many factors: maternal, whether anatomical, thrombophilia, genetics, immunological, infection. Also the embryo, the quality of the embryo. We know that we have 2 main parts here: the embryo, the quality of the embryo, and the endometrium. But we have many things that will affect. The male factor itself might affect. The IVF protocols, the obesity, the smoking, the habits, many things can affect the implantation rate. And since we are talking about the uterus here, I will concentrate in my talk about the receptivity of the endometrium, the receptivity, and especially in repeated implantation failure. Now, many interventions were promised to improve the receptivity, but I will talk about 5 interventions: the immune therapies, endometrial scratching, endometrial receptivity array, platelet-rich plasma, and SCG. I hope I will cover them quickly in these minutes. Immune therapy. Maternal immune system function will change definitely at the time of implantation. The mother or the maternal system has to change to accept a semi-foreign embryo and kind of immunosuppression. The theory about the immune factor is that maybe something wrong went in this immune system, leading to the rejection of the fetus. And they incriminate here the uterine natural killer cells, and they attack the fetus and abort the implantation. But investigations showed that these natural killer cells in the uterus are in contact only with the placental trophoblast and not the fetus. And in vitro studies showed that they cannot kill trophoblast in vitro in order to reach the embryo proper. So this mechanism is questioned. Although, despite this, steroids, I will talk about 3 modalities in the immune system. The first is corticosteroids. Steroids are commonly offered to our patients. Many of us has offered this, but what's the evidence? In 2012, there was a Cochrane meta-analysis, including 14 studies, showed that there is no clear benefit using steroids. More than this, in 2018, a practice committee of ASRM concluded that there is sufficient evidence to recommend against the routine use of steroids. It's harmful to give steroids. What about the safety of steroids and the growing embryo? Studies showed that there is possible causal association between steroids and the risk of oral cleft, major congenital anomalies, prematurity, low birth weight. So, on the other hand, studies showed that controlled inflammation and activation of the immune system is also necessary for a successful implantation. So maybe you are interfering with this implantation. So unless there is clear evidence for the use of steroids, these are harmful. And even FDA assigned category D for steroids and using steroids. What about intravenous immunoglobulin? The effect on the immune system is complex, and even its effect on the uterus at the time of implantation is unknown. In 2018, from the practice committee, same practice committee, systemic review, including 2 small trials, because we don't have many trials here, they showed that there is no clinical benefit. More than this, IVF requires a medical facility to give. It has adverse reactions, including tachycardia, thromboembolic complications, anaphylactic reactions. It's very expensive, $2,000 to $14,000 per IVF cycle, and even the UK Department of Health does not recommend IVF. What about the granulocyte colony stimulating factor? It's a cytokine secreted by immune cells. It can be given either by intrauterine instillation or subcutaneously around the time of implantation. The rationale for its use remains unclear. Cost between $100 to $600. A systemic review in 2018, 10 RCTs reported possible benefit from it. But another meta-analysis in 2018 also concluded that may have a beneficial role only in RIF cases. But when you review these studies, many lacked clear description of randomization, were heterogeneous, and did not measure live birth, only pregnancy. So this is why at this time there is insufficient evidence to recommend for or against the use of this medication or this intervention. Maybe I'm going too fast, but the time is short and we have to cover the material. Now, the second intervention is endometrial scratching. We use it to injure the endometrium by a pipette. It's used in the luteal phase of the cycle, prior to the cycle of IVF, because studies show that if you use it before in the same cycles, it's harmful. The mechanism said that the resulting inflammation and activation lead to activation of immune pathways, suggesting to improve the receptivity in the second. But there is questioning of this mechanism, because what inflammation and what activation occurred in that endometrium is lost because we have complete shedding of that active layer of the endometrium before the next cycle. So questioning the mechanism. Despite this, this intervention is used very commonly around the world, and it was very common in the 2016, 17, 18, and I think it's still being used nowadays. So what's the evidence? A Cochrane review in 2015 showed about a possible benefit of this intervention, but only in RIF patients. A number of recent systemic reviews also showed beneficial effect, but a large trial, more than 1,300 women, control randomized trial, published in the New England Journal of Medicine in 2019, showed no benefit whatsoever, even in the subgroup of RIF patients. So this is the randomized study, no benefit. Even after the publication of the New England Journal of Medicine and no benefits, still others are publishing, and some researchers consider that it should be abandoned. Others still believe that there is some benefit of endometrial scratching. Now it is safe, it has safety, it's just some cramping, it's not something, it's not expensive, but with the current evidence, we cannot advise for or with or against, and maybe one has to individualize the cases. The endometrial receptivity array. This is a la mode nowadays. Now, since 2003, many studies demonstrated different genomic signatures between pre-receptive and receptive endometrium, meaning that the genes that are active at a certain place, the transcriptome or the genomic signature, might differ with the timing during the window of implantation. Also, in other studies showed that this endometrial transcriptome is different in cases with the diagnosis of RIF. Because of these studies, they say that the window of implantation or the time of the receptive endometrium is in a narrow window. We do not have really that day in days. It's maybe less than 1 day for that endometrium to be receptive and to receive. This is the theory around this test. So because of these studies, in 2011, Gemino et al. Used the microarray the assays, the endometrial called the endometrial receptivity analysis or arrays or ERA, measuring 238 genes simultaneously at different points during the window of implantation. And he stated that that ERA test is more accurate than the regular endometrial biopsy and the histology in dating the endometrium and knowing the window of implantation better than other tests. In 2013, and sponsored by a commercial company, we know the iGenomics, etc., the company uses this ERA test to show that 25% of patients with RIF are out of phase. They have altered window of implantation. They are not receptive if we count them by the 5.5 days of progesterone exposure. And they started preaching that let us use this ERA testing in order to personalize the timing of the embryo transfer, what we call PET, as a therapeutic model for cases of RIF. Another study, 2018, supported high incidence of altered window of implantation in RIF. However, most of these studies, and the majority of these studies, I have to mention that they are sponsored by the same company, the commercial company. They have a small number of patients, no accurate follow-up. The studies were unable to conclude also a clear and significant benefit from ERA and personalized embryo transfer in RIF. Another thing that study suggested that ERA testing showed 25% of patients out of phase, but also 12 to 15% of control group were also out of phase. So we have what we say false positive ERA testing. There is something false positive testing of ERA. Now, the company itself sponsored the only randomized study examining the utility of ERA in patients undergoing the first IVF cycle. And they showed the authors that there is increased benefit in the pregnancy rate, but not in the live birth rate. So up till now, there is no evidence that ERA increases live birth rate. The ERA test is available from a single diagnostic company. And despite we do not have robust evidence, we know that many around the world are utilizing this expensive modality or intervention. We believe that the evaluation of this ERA should be performed by an external independent researcher. But why those non-company sponsored RCTs difficult to do? Why? Because the cost, if you want to send your test to the company, the cost of each one is $800 per test. And if you want to have an adequately powered RCT, you need more than 1,000 women. You divide them 500 by 500, so you have to pay $400,000 US only for the ERA test alone. But this will be followed by endometrial biopsy, freeze-all cycle, repeated medicated frozen cycles, transfer, again doing the biopsy. All these will add to the extra expenses of this study. And this is why nobody is really interested as an independent researcher to go and do such a study. Enough for ERA test. We come for the platelet-rich plasma. Platelet-rich plasma is still experimental intervention. And in the beginning, it was used initially to treat thin endometrium. The several small observational studies demonstrated a positive impact on endometrial thickness and pregnancy rate, but these are small and not really well randomized. The largest available RCT was performed in 2019. 138 RIF patients showed a possible benefit. But another study, 2020, investigated the use of PRP in patients with normal endometrial thickness, and they could not see really any improvement in the pregnancy rates. So most existing studies are limited by small numbers, lack of randomization, suboptimal control groups, and with this, we can conclude that PRP and RIF is still not recommended. The last intervention I will talk about is HCG. HCG can be given by intrauterine infusion around the time of embryo transfer. We know that it upregulates cytokines. We know that HCG is important in its action on the endometrium. So the theory was that if you maybe there is lack of its action, if you give HCG, it might improve the implantation rate. So a 2018 Cochrane review showed that in that study, the studies they reviewed showed a high heterogeneity between trials, unable to pool the trials to have an adequate meta-analysis and decision. There is an increase in live birth rate only in the subgroup of women undergoing cleavage stage, day 3 embryos, but not blastocyst, and the dose should be more than 500 compared to control. Nowadays, the current evidence does not really support the use of HCG injection in routine practice. take-home messages from this short communication. Immune therapies, definitely not recommended, but even harmful. Endometrial scratching, there is no consensus. There is evidence against, evidence with, but the New England Journal study is against, so maybe it's more towards the against. Endometrial or ERA, we need independent RCTs, as I mentioned. PRP not recommended, and SCG, no evidence of benefit. I will leave there for questions later, and I hope that I did not disappoint, I have not disappointed you, because all of us are using these interventions, but unfortunately the evidence nowadays is not with, it's more against, or at least not recommended. Thank you. I stopped my sharing. Rana? Rana is still there. She's not there, Dr. Abitayeh. George, are you hearing me?
Here, but I think she's muted or something like this. She's not hearing us.
Maybe she has to click, or Science Pro, they have to unmute her.
Thank you, Dr. Hanoun, for your very beautiful presentation. We'll leave the questions for the end of the webinar.
So yes. I'll go out and mute myself, okay?
Thank you,
Talk to you later.
Now we'll present Dr. Teddy Tadros. He's an IVF specialist also. And he will talk about hysteroscopy in IVF. Dr. Tadros is in Hopital Aboujaoude, and the floor is yours, Dr. Tadros. Thank you.
Thank you, Dr. Abitayeh. First of all, I would like to thank the Lebanese Fertility Society for the invitation. Today, I will be talking about the role of hysteroscopy, and mainly diagnostic hysteroscopy in vitro fertilization and in implantation. As you know, hysteroscopy, even in the era of 3D ultrasound and hysterosonography, remains the gold standard in the evaluation of the uterine cavity. It is a quick, minimally invasive procedure which can be performed in an outpatient setting and even in an office setting. And according to the French College of Obstetricians and Gynecologists, hysteroscopy is indicated when uterine abnormalities are detected on ultrasound and or on hysterosalpingogram, such as polyps, fibromas, or synechia, and in recurrent miscarriage. But how about indications of hysteroscopy in vitro fertilization? And what is the optimal timing to perform this procedure? Here again, according to the CNGOF, there are 3 different strategies. So first, we can do it for all before the first IVF cycle and wait for the second or third failed cycles. And of course, if in case we detect in the investigation any abnormality on ultrasound or hysterosalpingography. So first, let us start with hysteroscopy for all before any IVF cycle. And I know that the vast majority among us are following this strategy. However, according to recent literature, it remains controversial, as for some, until 5-6 years earlier, the majority of the published articles favored this strategy. And Jyotsiana Pundir and her team published a review article and a meta-analysis suggesting that hysteroscopy may improve outcome. However, they concluded that large and more robust randomized controlled trials are further needed to corroborate this strategy. But contrasting with this theory, in 2013, the National Institute for Health and Care Excellence published their guidelines, and it was clearly stated that hysteroscopy should not be offered on its own because its effectiveness on improving reproductive outcome has not yet been established. And in line with this, Janine Smith published the results of the INSIGHT trial in the prestigious journal The Lancet in 2016, and in this randomized controlled multi-center trial, they followed up to 18 months, 355 women assigned to hysteroscopy before any IVF cycles, and 353 women who were assigned to immediate IVF. And what did they found? No significant difference in terms of implantation, clinical pregnancy rate, ongoing pregnancy rate, and live birth rate. Furthermore, Despizio Sardo and his team, in his meta-analysis published in a Human Reproduction Update in 2016, concluded that a robust and high-quality randomized control trials are still needed before hysteroscopy can be regarded as a first-line procedure in all infertile women. But now, how about hysteroscopy in recurrent IVF failure? Unfortunately, here again, we lack in the literature for good quality randomized control trials, and the articles published remains controversial. But in 2016, El Touhi and his team published earlier many papers favoring hysteroscopy, conducting the trophy trial published in the Lancet, and demonstrated no significant difference in terms of clinical pregnancy rate, ongoing pregnancy rate, live birth rates, even in the sub-analysis of patients who received top quality embryos. But in the same line with repeated IVF failure, we have the repeated implantation failure, and one which is a cause of distress for both us, the physicians, and the patients, especially when everything on the paper seems apparently normal, and many have been trying to find an explanation and solution for this major problem. And one of these is endometrial scratching to improve implantation, which was suggested and performed many years earlier, and we took the habit to perform it mainly at the end of the hysteroscopy. We do both procedures at the same time. But a recent randomized controlled trials published in the New England Journal of Medicine, which Dr. Hanoun just presented, showed that there is no significant differences in terms of ongoing pregnancy rate, clinical pregnancy rate, live birth rates, or even improvements in recurrent implantation failure after endometrial scratching. Another suggested theory is chronic endometritis and its implications in recurrent implantation failure and recurrent pregnancy loss. It was reported more than 35 years ago, but the problem is that the diagnosis is very difficult, and even it can be missed on histologic exam. Ciccinelli and his team demonstrated in two papers published respectively in 2005 and 2018 that hysteroscopy can help in the diagnosis, especially when we have micropolyps less than 1 millimeter, stromal edema, and focal or diffuse hyperemia, which may be signs of endometritis and help us diagnose immediately and suspect a chronic endometritis. And in 2015, the same group demonstrated a significant amelioration in IVF ET results in patients treated for chronic endometritis. But according to the authors, their study was limited by its retrospective nature and a high possibility bias in the selection of patients. However, parallel to this publication in the same year, a group in Montreal published an article, Infertility Specialist, on the role of hysteroscopy and now the use of immunochemistry in chronic endometritis. And they showed a fair high prevalence of chronic endometritis in recurrent implantation failure and even higher in recurrent pregnancy loss. However, due to its small size and the high number of physicians performing hysteroscopy, the results need to be carefully interpreted and wait for larger studies with treatment protocol and follow-up to verify any benefits after the diagnosis of this pathology. Now, the content of the next few slides will perhaps be one of the near future way of understanding some of the causes of recurrent implantation failure with top embryo qualities. So I would like to catch your particular attention, especially we are talking about hysteroscopy, a role of hysteroscopy in this new trend. Recently, a new trend is taking place, and in line with this, with what preceded with chronic endometritis, is the uterine microbiome. And as you know, until recently, the uterus was considered to be sterile, and the sterile womb paradigm, which was coined by Henry Tissier in the 1900s, was a commonly believed dogma, and which stated that human infants develop within a sterile environment. However, the assumption of a sterile, healthy uterus was challenged by multiple reports in the second part of the 20th century, which used culture-dependent method to show bacterial colonization in the uterus from 0 to 90%. Unfortunately, it is now acknowledged that only 1% of bacteria are culturable. However, in 2007, with the advent of the next generation sequencing technologies, it is now becoming clear that the uterus has microorganisms with roles beyond infection. And a pioneering study by Chen and his colleagues, where he analyzed the microbiota along the female reproductive tracts in 95 women, showed that contrary to the vagina and to the cervix, where lactobacillus is dominant in 99% of the cases, the floor and the microbiome of the uterus is very different, with bacteria like Pseudomonas, Acinetobacter, and Vagococcus, etc., are dominating bacteria in the uterine and the endometrium. And since we are witnessing many more and more publications about the uterine microbiota and their implications in implantation and the possible use of hysteroscopy to analyze this uterine environment by performing an hysteroscopy, taking a biopsy, and studying with the next generation sequencing this uterine microbiota. So I wanted to shed the light on this new foundings that we are talking about. Maybe it will help us in the definition of recurrent implantation failure, and maybe it will help us to find new strategies to treat these patients. And of course, without hysteroscopy, we cannot identify these probable pathologies. So let me conclude, Mr. Chairman, that routine hysteroscopy should not be performed or offered to asymptomatic women with normal ultrasound scheduled for their first IVF embryo transfer cycle. Until now, there is no clear benefits of hysteroscopy in recurrent implantation failure. However, it may have a probable role in identification of chronic endometritis and the uterine microbiome, which might procure a positive impact in recurrent implantation failure and recurrent pregnancy loss. And thank you for your attention.
Okay, so now I'm sharing. So will let me know when you see my presentation, please.
Yeah, Habib, it's on.
Okay. So first of all, I want to thank the Lebanese Fertility Society, where I'm a member, for inviting me for this presentation. And I'd like to thank Dr. Georges Abitayeh and all the attendees this late afternoon. So the subject today, I'm going to talk about uterine malformations and their association with fertility, if there is some. Up until now, what is the evidence really for this problem? This is a very big chapter. I'm going to try to stick to the time, so bear with me. There are interesting things, especially at the end. So just a quick reminder for the embryology stages of the female reproductive tract formation. So mainly we have 3 steps: the development of the Mullerian ducts, then by the 8th week, the fusion of these ducts, and starting the 9th week, the resorption of the midline fusion line. So we might have problems in these 3 steps. So what is the prevalence of these congenital uterine malformations? We should know that many patients are asymptomatic, meaning while we are doing our C-sections, for example, we are surprised to find that this is a unicornuate uterus, or this is a uterus with a septum that goes up to the mid-level of the uterine cavity, etc. But in general, studies shown that the prevalence is between 4.3 and 6.7% in the general population, a bit higher in the infertile population, up to 8%, and in the special population of recurrent pregnancy loss, it can go up to 18%. Now, the main problem that has been and still is present is that there is no universal classification system. There is the American Fertility Society classification that was adopted for decades, and still it's the ASRM classification. And there is the new ESHRE classification, and in between there are many tentatives to make new classifications. I'm going to talk only about the ASRM and the ESHRE due to the lack of time. What is important to mention is that up until now, there is not one single randomized controlled trial that is comparing acting or not acting, treating versus non-treating of these uterine malformations. All the studies are observational or prospective descriptive studies. And this will limit the conclusions that are available and the data that we have in our studies. So to diagnose a congenital uterine malformation, the gold standard was and still the laparoscopy and hysteroscopy. But during this last decade, because there was a big revolution in ultrasonography and in detecting uterine malformations through 3D ultrasound or 3D hysteroscopy or even pelvic MRI, we are now using, especially if we are going to classify by the ESHRE classification, we are using only 3D ultrasound or 3D hysterosonography with or without pelvic MRI, and we are able to detect almost 100% of congenital uterine anomalies. And we are going to leave the laparoscopy and the hysteroscopy for the treatment and the same time as defining the diagnosis. So I'm going to start with the ASRM classification. So this is a little bit modified from the AFS, long known since the 980 years. So it's like 45 years till now. So we must know that it's 7 classes. The first class is the hypoplasia class. The second, the unicornuate class. Then the non-fusion didelphus, bicornuate partial fusion, septate and arcuate, it's the absence of resorption, and at the end, the class 7 is the DAS, drug-related. This classification is only for the uterine anomalies and does not doesn't have any description for cervical and for vaginal malformations. So this is a common, if you want, weakness of this classification. And at the same time, for the septate especially and the arcuate sections, we do not have a definitive diagnosis. We do not have a morphometric criteria, for example. We do not have real measurements. That is why many have tried to do a new classification. I'm going to skip until 2013, when the ESHRE and the ESSI consensus on the classification of female genital tract congenital anomalies surfaced. So this was a complete classification: uterine, cervical, and vaginal. Today I'm going only to show the uterine anomalies. So they classified them in 7 classes mainly. U0 was the normal uterus. U1 was the dysmorphic uterus, which is the T-shaped uterus, DAS, and the infantility uterus. There is no arcuate uterus, there's only septate uterus, the class U2. And here the definition went morphometric, meaning they put criteria. So the main criteria is that they will draw a line for the they call it the interstitial line. It goes from the both of tubal ostia, and starting this line and up until the whole thickness of the fundus, they will measure the myometrial thickness. And the diagnosis of a septate uterus means that if we have an internal indentation going from this horizontal line downwards, if this measurement is more than half of the myometrial thickness, it will go for a septate uterus. Likewise, for the class U3 bicorporeal uterus, it's the same measurement of the myometrial thickness. And if we have an external indentation that goes beyond 50% of this thickness, we will diagnose a bicorporeal uterus. Of course, associations are always present. We can have both of them, meaning bicorporeal uterus and septate uterus at the same time. The class U4 is the hemiuterus, the unicorn with or without a rudimentary corn, and the class 5 is the aplastic uterus, so the Mayer-Rokitansky syndrome, with or without remaining horn. The class U6 will remain for the unclassified malformations. So it was the first time when a classification really made a few clear criteria. But what is the clinical significance of these criteria? Are they applicable? Can we rely on them? What are the results? In the same time, the ASRM, because the ASHRAE had defined these morphometric criteria, the ASRM issued their own update, if you want, especially for the uterine septum criteria. So it's the same ASRM classification, but here they defined measurements. They said if we have in the same criteria, the same interstitial line, if we have an internal indentation that is less than 1 centimeter with an angle, with an open angle of more than 90 degrees, we call it normal uterus. Between 1 centimeter and 1.5, it's not shown here, it's arcuate uterus. For the septate uterus, the internal indentation should exceed 1.5 centimeter with an angle that is less than 90 degrees. And for the bicornuate uterus, we should have an external indentation that exceeds 1 centimeter. So here, I am going to try to give you what are the problems of this classification. I want to emphasize on this before going further, because this is very important. This is 3 rows, all of them are different patients. The first row, we have an internal indentation that is here and here, that is less than 1 centimeter. According to ASRM, it's a normal uterus. According to ASHRAE, without even measuring, we can clearly see that the thickness is by far more than 50% of this thickness that is remaining, which is the myometrial thickness. So according to ASHRAE, all these are septate uteri. But for the ASRM, they are normal uteri. For the second row, it's between 1 and 1.5. So according to ASRM, these are arcuate uterus. According to ASHRAE, of course, they are septate. And for the third row, it's the same, both of them are septate. So clearly, using the new ASHRAE classification, we are overdiagnosing a lot septate uteri. So in the same way, because this has happened, ASHRAE said maybe we do not have access to a mid-coronal plane to measure the myometrial thickness. Maybe we should find another way to measure this myometrial thickness, and they hoped that that will decrease this error or this increase in diagnosis of septate uterus. So clearly, they said on a 2D plane, mid-sagittal 2D plane, we will measure the anterior myometrial thickness, the posterior one. We will add them together and we'll divide them by 2. So by that, we will have the average of the myometrial thickness. And we will use it as a reference for comparing this indentation. What was the result? They went into a pitfall again. These are 2 different patients on the left and on the right. They have exactly the same measurement of internal indentation of 0.61 centimeter. If we are going to stick to the, let's say, the main option where we measure this thickness, this patient has a septate uteri. If we use the alternate option, as they called it, we'll measure these both, add them together, divide them by 2. This A is more than B, meaning it is a septate uterus. For the second patient, clearly it is a septate uterus if we rely on this thickness, but if we measure the anterior and posterior, add them together, it's not a septate uteri. So inside the same ESHRE classification, we are falling again in the same pitfall. So clearly there is a big problem in this classification, especially in the septate uteri class. So this paper in 2018 ended, and it's clearly said clinicians exercise caution when offering surgical correction to patients who are diagnosed as being partial septate uteri using the new ESHRE and SG classification. To summarize, what is the evidence that we have for uterine septum and its effect on fertility? There is insufficient evidence to say that a uterine septum is associated with infertility, and that is a grade C recommendation. We have no randomized control trials, as I said before. What we know is that uterine septum can be associated with worse reproductive outcomes, meaning we can have more miscarriage, more preterm birth, more malpresentation, IUGR, placental abruption, and perinatal mortality. I'm not going to say them all. As a summary, we should pay attention. If we are using the ESHRE as a classification, we are over-diagnosing, we are over-indicating, if you want, surgical intervention perhaps for arcuate uterus or even normal uterus according to SRM, and we are going to operate them. So we should pay attention not to over-operate patients. And at the same time, there is a benefit for operating patients that are symptomatic, that suffer from early miscarriage or preterm birth, etc. And there is no really data that says that monopolar energy is better than cold scissors, is better than laser, or is better than bipolar energy. All of them are the same. All the recommendations are grade C. If we should put the anti-adhesive agents inside after resection or not, there is no, up until now, we have no RCT that confirms if it is with or against. So this is to close the septate uteri, because really there is a big debate now for the classification, what we should do. Rapidly, for the dysmorphic uterus, there are 2 large, again, retrospective studies, Fernandez et al. And Meyer et al. We know that in T-shaped uterus, especially DAS, surgery, meaning enlargement of the endometrial cavity, improves both fertility and obstetrical outcomes, meaning for a patient that is infertile or that had implantation failures, we know that the surgery increases its chance for pregnancy rate and for live birth rates. Live birth rates, pregnancies were almost after metroplasty 50% in the first series, and with a live birth rate up to 73% in Fernandez et al. Group and in 57% in Meyer et al. Group. And also, most interestingly, the miscarriage rate decreased from 80% to 27% in Fernandez series and to 16% in Meyer et al. Series. So the surgery is a section of the lateral uterine walls going from the tubal ostia down to the internal cervical os, just to increase the capacity of the cavity. And again, the energy, there is no difference. There was no randomized. We don't have the evidence to say use monopolar or use bipolar or use scissors or etc. I will move on to the bicorporeal uterus. So it's like half of the congenital uterine anomalies. We know that there is no impact on fertility for this kind of malformation, but there is exact evidence, there is sure evidence that there is increased mid-trimester pregnancy loss and preterm birth. Usually for we do not operate these patients. The only thing that we can offer for these patients is when we fail in medical treatment to have a live birth rate, whether preterm or term pregnancy. Meaning when we fail in medical treatment to reach a live birth baby, then we can suggest for this patient the Strassman surgery, which is the metroplasty. We combine both of the cavities, and in some series, the term delivery rates can go up to 90%, especially in these patients when all fail. The class U4, the hemiuterus, it's really most rare, and it's 4.4% of the whole of the uterine anomalies. In almost more than 20% we have associated urinary tract anomalies, and about 20% we have associated endometriosis. So this is complicating even more fertility and reproductive outcome. And really in this section of patients, it's a case-by-case scenario, because there are multiple different factors that will even intervene even more. For example, the vascular contribution, especially from the contralateral aplastic side. This is a major factor. The muscular mass of the remaining functioning uterus, and the cervical competence. So the highest live birth rates were with women who had a rudimentary horn with or without a functional cavity, because it's of the vascular contribution from the contralateral side to the functioning side. It was about 35%. Now, should we operate? Should we remove this rudimentary horn or not? The only consensus that we have is that women who have non-communicating rudimentary horns with endometrial cavity, with functioning cavity, these are subject, we should remove laparoscopically their rudimentary horn, because they will have a lot of pain. Usually they have a lot of pain. They have retrograde menstruation, so they have more endometriosis, and at the same time they risk a tubal pregnancy. So we should remove them before opting for any fertility treatment. For the other type of horns, there is no consensus on operating. I will end my presentation with this class 5 aplastic uterus. So it's the Meyer-Rokitansky-Kuster-Hauser syndrome. It's about 3% of all the congenital uterine anomalies. The prevalence is very low, around 1 among 5,000 people. So up until, let's say, the year 2000, even for the year 2013 or 14, what did we offer for these patients? We used to tell them, most probably you will have no children. You cannot have children, you don't have the uterus to hold the children. Their options were either to go for adoption, or to go, where applicable, of course, for gestational surrogacy carrier, meaning they will put their embryos into the womb of another woman. She will carry the baby, and then after delivery, it's their baby after all. But this really question of the gestational carrier has many legal issues, because a few countries have it legalized. Ethical issues, religious issues, social issues. There were many studies that were done in countries like Japan, for example. They used on thousands of people. They would ask them, if you have this kind of malformation, what would you do? Would you go for a gestational carrier? Or if there is an experiment, for example, of transplanting a uterus, would you go for it? Only as an experiment, there is no real results. Even if a gestational carrier has good results, most of the people said no, they would go for experimentation. They would withhold going to a gestational carrier. So it's a really high burden option for them. And uterine transplantation can be something really interesting. So what is the history of uterine transplantation today? It's a rapidly expanding field. The first uterine transplantation ever was done in Saudi Arabia in the year 2000. It was from a live donor, and it was from an open laparotomy technique. Unfortunately, at the 9th month, there was a necrosis of the graft, and it had to be removed. It had to go for 11 years later, when in Turkey, there was one publication of a deceased donor uterine transplantation that the graft survived after 3 months. This is the cutoff, it's 3 months survival, but there were 2 early miscarriages. There was not a live birth rate. And then came the change with the Gothenburg group in Sweden in 2013. So they published most or likely big data. It was 9 live donor transplants that were done with the same technique, open laparotomy technique. There were 7 graft success and 2 graft failures. Among these 7 graft success, there were 8 healthy babies that were they were born between 2014 and 2017. The same group tried to decrease the morbidity of the operation, especially for the donor. So they tried to do a live donor transplant through a robotically assisted laparoscopy. It was a graft survivor, but up until now, there is no live birth rate. And then many countries have many medical teams had tried to do transplants either from live donor, deceased donor. In US, there was 5 live donor transplants, but there were only 2 graft survivors and 3 graft failures. So it's really in the experimental phase. It's really in its infancy, the uterine transplantation, but it's really promising. Now, the main problem of the uterine transplantation, I'm almost done, is that it's a radical hysterectomy. So for the donor, it's really high risk surgery with a high morbidity. And the main problem, the main issue is that the uterine artery should be dissected until its origin. That is for sure, because we need length for the transplant. And what is more difficult is the uterine vein, because it's close contact with the contact with the ureter, and because it has many collaterals, many communications, and we could easily damage this uterine vein, and we have no other option. And at the same time, sometimes we must take a stump from the hypogastric vein just to have enough length to reach the external iliac vein, because the anastomosis are always in the recipient on the external iliac vessels on both sides. Now, there are some teams that try to say, well, if a uterine vein is sacrificed, then the donor will have to sacrifice an ovary, and we are going to use the length of the lumbo-ovarian vein, most probably, to try and have at least some vein drainage. That is, it's still unknown if it's sufficient or not. So this is the main problem. It's a high risk surgery. It's 6 hours of surgery for the donor and 6 hours for the recipient. What we must know is that we have healthy babies. The only healthy babies are only from the Gothenburg group. The technique was an open live donor hysterectomy with bilateral anastomosis of both uterine, artery, and vein to the external iliac vessels. This is the only success up until now. What we must know is it's still experimental with 1,000 plus. There are a lot of hypotheses. A lot of people are trying to postulate if you can only use lumbo-ovarian, we disregard the uterine veins, etc., etc. So it's really in its infancy, but it's really promising, and it's an expanding field, because it is going to work. It already worked. It's going to expand to other acquired pathologies and not congenital only uterine. For example, for patients who suffer from Asherman syndrome, etc., for polyfibromatous uterus, etc., etc. I'm going to end my presentation here. There are millions and millions of open questions regarding uterine transplantation. We can discuss them if you want now at the end. So I want to thank you. I'm sorry if I passed my allowed time, but it's really a big, I tried to cover all the sections of this pathology. I really thank you. And if someone has any question, I'm here.
Thank you, Dr. Atallah, for this beautiful presentation. Now we'll pass to the questions. First of all, there's some question for Dr. Hanoun. Dr. Hanoun, you are with us?
Yeah, I'm with you.
So someone asked you if you can brief a little about ERA tests.
Not about the uterus. This is not for me. I can
About
brief
ERA
about the
tests.
ERA test.
Yes,
What in
please.
specific the ERA test? Just to answer in brief, the ERA test, as I mentioned, it's measuring the gene activities more recently in 248 genes, and they are using the expression of those genes at different times or period of times during the implantation period. And they are making like maps and using this test to give the information of a certain endometrial biopsy. The physician will take an endometrial biopsy and send it to the company, and the company will give the physician or the patient that endometrial biopsy comes from either a receptive endometrium, a pre-receptive endometrium, maybe post-receptive, inadequate, proliferative, etc. It's like a diagnostic test. And when they give the answer of a receptive or receptive endometrium, they will ask the physician to transfer those embryos. In other words, the aim of the ERA test is to tell the physician, according to the company, that you go and transfer your embryos or the blastocyst at those specific hours or times or days in order to achieve a pregnancy. This is in brief. I don't know whether I could answer the one
No,
who
it was
asked.
perfect. Thank you, Dr. Hanoun. There's another question for you also. Someone is asking, what do you think about scratching done twice in proliferative phase and twice in secretory phase?
Maybe I read this.
Preceding a
From
cycle
Dr.
of
Shaban.
IVF. Yes.
From Dr. Shaban. Hi, Dr. Shaban. I did not come along such, to my knowledge, and we are doing the scratching 4 times. The theory is that we are hurting or injuring the endometrial lining more. But
Yes.
I mentioned in my talk about the rationale of this injury, because the mechanism, the proposed mechanism of function is that this injury will produce an inflammatory reaction and inflammation, a certain injury, and the effect or the influx of those inflammatory cells and the cytokines and all the factors will maybe help in the next cycle in achieving or improving the implantation, although we know that the whole functional layer where those actions are occurring, not in the basal layer, the whole functional layer of that endometrium that was induced with inflammation and with the injury is shed. All of it is shed. So what is kept for the next cycle, there is a big question mark. I don't know about these 4 attempts.
Did you hear me?
Hi, Dr. Shaban. Yes, we hear you.
Okay. لأنه the first publication about this scratching, it was about reported, I don't remember the author, but reporting like this. He did for patient who has repeated failure of implantation, this technique, and 12 of 13 of patients getting pregnant in IVF cycle.
Okay, Mustafa, but this is just one publication. It's not controlled.
Absolutely, yes, yes, yes. It's the first publication.
It's like we have
not controlled, exactly.
We have patients, and I can give many examples. So we cannot really depend on just one publication. I mean,
absolutely, yes. But I you know,
did you try it yourself?
Amazing. If
Mustafa, did you try it the 4 times?
No, never. No, I try 1 time. Normally, I do hysteroscopy before every IVF. In my opinion, in my office hysteroscopy without any anesthesia, it's helped me for everything. You know, first to look inside and see what's happened. Second, to wash the cavity. Third, to determine the way of transferring the embryo. And if there is any difficulty, we can do dilatation of cervix and etc. etc. So for me, it's not something نعمله زيادة. No, I think it's something interesting to do before IVF. Certainly in our patient, لأنه هون ما معهم مصاري يعملوها 10 مرات.
Mustafa, you mean hysteroscopy? Sorry to interrupt.
Hysteroscopy, yes.
Now talking about hysteroscopy, not the endometrium.
No, hysteroscopy.
But you see, Dr. Tadros mentioned that randomized studies, even in RIF patients who for hysteroscopy.
Yes, I agree. I agree. And we should follow recommendation, but recommendation is done in Europe. Okay, and as you know, they can repeat IVF for fee. In our country, maybe they can do it 1 time. Okay. إذا ما حبلت خلاص راحت عليها. But we should do everything to increase our success rate, I think. Maybe without any evidence base, بس ما بعرف يعني شو البراتيك تبعكم. أنا صراحة بعملها.
Okay. Thank you for sharing.
Thank you, Dr. Shaban. Thank you for sharing your experience.
Another question about uterine transplantation done in Bellevue, and what was the result?
I have no idea. I have no contact with the surgeon. I have nothing. I don't know if anyone has any idea of what happened with this case. I have no idea.
Habib, what do you think about hysteroplasty?
Which one? Do you mean for the T-shaped uterus?
Yes.
Well, actually, the problem is that what will I think? What would you think? But normally the data is consistent, is that there is an improvement, especially in worse reproductive outcomes. For example, there is a clear improvement in early miscarriages from 80% to 30%, even to 15%. But now we are speaking about retrospective studies. So the main problem in this whole pathology is that there is not one single randomized control trial that is going to tell you. But I think the problem is that it is not feasible. For example, if a patient comes to you, you're going to tell her, well, you have a T-shaped uterus. You are going to get operated, and maybe not. We already know that you will have maybe better outcomes if you get operated, but you may fall in the group that you're not going to be operated. So it's not feasible to do it. That is the main problem.
It's difficult for ethical issues also. If you have more chances.
Because we know she will have better chances maybe from retrospective studies, but are we allowed to say to the patient, no, you fall into the group that you are not going to be operated? I think this is the main problem.
We have two questions raising their hands. There's Dr. Khadoun Khmaisi from Jordan. If we can give him the microphone.
Hello, Georges, and hi, colleagues. Can you hear me?
Yes, we hear you. Yeah. Welcome, Dr. Khadoun.
I would like to thank you, Georges, for all these regular events, and we are very proud of you. My question is about uterine transplantation. I think it was Dr. Atallah who gave the talk. Very, very, very nice talk. And really, I mean, there is no shortage of patients for that, because we have a lot of congenital cases, plus the fibroids and the abnormal uteruses and so on. And there is no shortage of donors either. My question is, in the Middle East, how far do you think we are along that path? Do you think we are, reaching a stage where we can offer it to patients, or shall we send them to Sweden? I mean, I understand in Lebanon, maybe you've done one case, is that right?
Well, actually, in Lebanon, there was a reported one case that was done in Bellevue Medical Center, but as I said before, I have no idea what happened to the patient. I don't know if someone has, but I doubt it. Now, in the Middle East, mainly, even in Europe and even in US, mainly the live donors were from the same family, meaning it's a mother who gives her child, or it's a sister who gives her sister. So even in Europe and US, that is what's happening. So I think this idea could be really plausible. So I think it is applicable in the Middle East. Now, of course, it will remain the whole medical staff, meaning from the surgeon, etc., etc. And most importantly, it's religious barriers. Let's say ethical, if we don't want to say ethical and religious, and most importantly, legal, because I don't know if any country will legalize this thing, meaning it's a really big step forward. But I think we should not be so far from this, because at the end, it's her mother giving the womb to her child, for example. So I don't know. I think it's an open discussion. It's a really long discussion with all medical staff, in all Arab countries, we have religious regimes. So it's really gonna hurt multiple barriers. But I think this is the future, especially for the acquired. The congenital, okay, we know it. But especially for the acquired, because we are seeing more and more Asherman syndrome, polyfibromatosis, etc., etc. So I'm.
Thank you.
Thank you, Dr. Khadoun.
Thank you very much.
I'm happy that you are with us today also. There's another question from Dr. Naba.
Good evening, dear friends.
Hi,
I want to thank you. Miss you all. I want to thank you all for the excellent presentations during this outstanding webinar. I have two small questions, please. The first one for Dr. Tedros. Is there a place for the testing for an eventual lower percentage of lactobacilli or endometrial microbiome? as it may be associated with a poor reproductive outcome or the EMMA test. And if you allow me another question to Dr. Habib Atallah.
Yes, sure.
Is there a place for the Buttram, for the all classifications, Buttram and Gibbons in the US, or the Musset classification in cases which are not related to infertility? So whenever we have classifications of ESHRE or ASRM, the old classifications are gone.
Dr. Teddy, if you want, I will answer later.
Yes, hello, Dr. Naba. Thank you for your question. As for lactobacillus, I think it was presented as an oral presentation about 2 years ago, I think, in ASRM, and stating the role. It was a test on 6 patients. Where they tested the lactobacillus in the vagina, and when they treated the patient who lacked of sufficient colonies of lactobacillus, they proved there was an improvement in implantation and pregnancy rate, but it was a mini series, so we can't rely on it. But as I said, it's a new trend in medicine, because we are in 3 years ago, when I was at Foch Hospital, I remember Dominique de Ziegler was talking about the uterine microbiome, and was telling this will be the future in implantation. So it's a new, it was stated long ago, but now we are seeing the many publications on this item. So I think we have to wait for new publications, but I think there will be a role for lactobacillus and maybe other bacteria in the uterine environment.
Dr. Naba, as for your question, actually for the classification of Gibbons, it was, let's say, updated, or it was the AFS, so the American Fertility Society. So the American Fertility Society that was installed in 1988, the first classification, it was a reference from the Gibbons, if you want studies. And then it's the same classification that is now called the ASRM classification, but with an update that was done in 2016 that went a little bit, let's say, like ESHRE, or a little bit objectively more, just to remove the subjective part of it, meaning it went to say, you will measure the internal indentation. If it's less than 1 centimeter, it's normal, between 1 and 1.5. Now, there is, for example, the WIQWAM classification, which is based on an oncologic base. It's very complicated. If I want to put it, it's like 10 slides. So actually, the problem here is to make a classification that is simple to use, and at the same time that can be standardized for all the international communities, let's say. So we can do maybe so we can do a good randomized control trials, or to have better conclusions, to have better evidence, to at the end to make good recommendations or better recommendations. The problem is that there are thousands of classifications. The classifications of Musset is I'm sure it is still being used in France, but now with the ESHRE, people are trying to change. But you see the problem, for example, of the septate discarding the arcuate uterus. You know, there is not really a good evidence, because the morphometric criteria were installed in only these, and only the septate uterus, when they said 50%, etc. But actually, it has been proven that there is a big problem in this section of classification. And yes, most probably, for example, either they are going to change it, or we're going to move to a perhaps better classification. And I think the ASRM, it's my opinion, it's still the best. It's incomplete because it doesn't have the cervical and vaginal malformations associated to it. But I think for the uterine anomalies, the ASRM is still the most used worldwide.
Thank you. Thank you.
Thank you for your question, Dr. Naba.
There's other questions? I don't think so.
In the Q&A, they are answered.
Yes.
Okay.
Dr. Hanoun, you have any take-home message like this?
You see, I don't
Highlight.
want to take more time, but I agree with all the attendee and with all of us that repeated implantation failure is really a frustrating situation facing the physician and the patient. And many times one is compelled, maybe, I'll see one has to do something. Although many times the evidence and the randomized controlled trials and all these things not showing a real benefit. We know this. We've been in the IVF maybe for now 30 years. And we know that when you are facing a patient who keeps asking you, why did I fail? Why, doctor, I failed the IVF? The first time you tell her, maybe because it's random, bad luck, you know this, because we don't have 100% success rate. Maybe in the first cycle, in the first failure, the patient would accept, the couple would accept. Now, the second time, the same question, why did I fail? Do I have anything, etc., etc.? But I want to say, to relay the message, and don't feel harm or don't feel that, okay, we cannot do anything. Maybe my message at the end, we have to individualize cases, because many of us are really, they find themselves maybe obliged to do something for that patient. Is it psychological? Is it something like this? We don't know. The third time, definitely it becomes unacceptable. And even if you don't do anything, that patient would think that that physician doesn't know what I have or what's my problem. And they keep shopping from one center to another, etc. Till somebody is obliged maybe to intervene in a certain way, and that patient will conceive. Was it from that intervention, or was that physician lucky? We don't know. So what I want to tell that we try to stick with the evidence-based instructions, but many of us would use those interventions, although maybe not convinced 100% that they might help. This is my message. Don't feel bad if you are using these interventions, and we are telling you that the evidence base really does not help you. So sometimes you are obliged to do something.
Thank you, Dr. Hanoun. Any other comments from Dr. Atallah or Dr. Tadros?
No comments from my side. Thank you all for this good webinar, and thanks for all the attendees.
Thank you all.
Thank you for all the attendees to be with us tonight, and hope they enjoy our fourth webinar. I want to thank our speakers, Dr. Hanoun, Dr. Tadros, Dr. Atallah, for their clear and useful presentation. And a big thanks for our chairman, Dr. Tell, for all her efforts despite all her technical problems.
Yes.
Yes. So thank you very much for all your efforts. Big thanks also to Merck and its team who help us to make this webinar happen. Thanks for Sciences Po all the time for all the technical support. And waiting for you for our next series of webinar in July entitled Best of Ishri, after the Ishri Congress. Thank you again to be with us tonight, and have a good evening. Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.